This is going to be a presentation about operative vaginal deliveries and a review of pelvic shapes. Let's review the indications for operative vaginal deliveries. The first is maternal exhaustion, inability to push effectively, medical indications such as maternal cardiac disease, a need to avoid pushing in the second stage of labor, or a prolonged second stage of labor, arrested descent, or rotation of the fetal head, and a non-reassuring fetal heart rate patterns in the second stage of labor. Some important prerequisites for operative vaginal birth to keep in mind are that the cervix must be fully dilated and effaced, the membranes should be ruptured, the fetal head must be engaged, the position of the fetal head must be determined, an EFW should be performed, the pelvis should be adequate for vaginal birth, anesthesia should be adequate, the bladder should be emptied, and the patient, of course, has agreed after being informed of the risks and benefits of the procedure, and there must be a willingness to abandon a trial of operative vaginal birth, and a backup plan should be in place in case of the need for an emergent cesarean birth. It's important to understand the anatomy of the forceps so that safe and effective use can occur. These are two figures that I think are helpful in understanding all of the parts of the forceps. At the end of this presentation, there is about a link to a 2-minute video that has a little bit more in-depth discussion of the anatomy of the forceps. The blades may be fenestrated or solid, and they have two curves. There's a cephalic curve that protects the fetal head, and a pelvic curve that accommodates the maternal pelvic curve. The tip of the blade is called the toe, the back of the blade is called the heel, and the shanks may be overlapping, such as an Elliott type forceps, or parallel Simpson type forceps. The shanks meet at a fulcrum point where the joint locks them. There's several different lock configurations. There are the English type and the sliding lock type. The handle is used for gripping the forceps. And it's important to know that each feature of the forceps are designed for a specific purpose. And this is usually a high-yield tested topic on CREOG. Fenestrated blades allow the infant's cheeks to bulge through and prevent slippage on the baby's face. And fenestrated blades, however, fenestrated blades tend to leave bruise marks more readily than solid blades. Pseudo-fenestrated blades, which is the Lukart modification, those try to combine some of the benefits of solid and fenestrated blades. Overlapping shanks, such as seen in Tucker-McLean forceps, have more space towards the heel of the blade, which makes them more favorable for a delivery of an infant without molding. The overlapping shanks also cause less stretching of the perineum and are much better for rotational maneuvers. So again, Tucker-McLean forceps and overlapping shanks are better for rotational maneuvers. Parallel shanks are longer blades. Those are like the Simpson type forceps. Those are very helpful when there is significant molding in caput present. Also, the sliding lock of the Kielins in Barton forceps help to correct asynclitism. There are several types of forceps deliveries. The first that we'll review are mid-forceps deliveries. Those are when the fetal station is above +2. The next is a low forceps, where the leading point of the fetal skull is at least at +2. And then you can have without rotation or with rotation. Again, with rotation is when there's more than a 45 degrees needed to correct to the OA, direct OA position, usually done with the Scanzoni Maneuver. Outlet forceps are when the fetal scalp is visible at the introitus without separating the labia, when the fetal head is at or on the perineum, and the sagittal suture is in the AP diameter or also known as direct, or ROA, ROP, LOA, or LOP. This is a brief review of the Scanzoni Maneuver. First, as seen in Figure 2a, you correct the astigmatism with articulation of the forceps shanks, and then you start to flex the neck by moving the blades parallel to the maternal thigh, and then using a wide arc complete the rotation from an OP to an OA position. CREOG usually likes to test the use of specialized instruments. This is a high-yield topic. The first type we'll review are Keelan's forceps. These were developed in 1915, and there are significant modifications to this forceps. The blades have a very slight pelvic curve, and the shanks are overlapping. The knobs on the fingertips help identify the anterior surface of the instrument. The Keelan forceps are really good at correcting rotational deficits because of the small pelvic curve of the blades. This allows you to rotate the forceps like turning a key. It's important that before applying the forceps to do a false application and hold them articulated with the knobs facing the occiput. Due to the lack of the pelvic curve, the direction of the pull is in the plane of the pelvic curve. So once the head reaches the pelvic floor, an extension is to occur, and it's important to remember that the handles should not be elevated above the horizon. Because of the lack of pelvic curve, when you elevate the handles, it digs the toes in the back of the vagina, causing very deep esophageal tears. Barton's forceps are the instrument of choice when there's a deep transverse arrest in a platypoid pelvis. This is because usually you have to deliver the fetus in an OT position. Piper forceps were developed in 1925, and they're specifically designed to facilitate delivery of the aftercoming fetal head in breech vaginal deliveries. The dropped handles allow direct application over the baby's head without the necessity of elevating the body above the horizon. The backwards bends also gives added traction, and there's no pelvic curve, which allows direct application to a high head. To briefly review placement of instruments, for a vacuum extraction, the cup should be placed 2 centimeters anterior to the posterior fontanelle and centered over the sagittal suture. It's important to make sure that there's no maternal tissue included. For a forceps extraction, it's important that the application is checked to ensure that the sagittal suture is aligned with the shanks, that the posterior fontanelle is 1 finger breadth above the shanks, and that the lambdoid sutures are equidistant from the forceps blades. Another highly tested topic are the pros and cons of forceps and vacuum deliveries. For forceps, the main advantage is that it's the most likely instrument to achieve a vaginal delivery and least likely to cause a neonatal cephalohematoma. The major drawbacks of this technique is that there's an increased risk of anal sphincter injury and altered fecal continence, and also they're not as user-friendly. So again, harder to call for in an emergency, more dependent on provider expertise and facility comfortability with their use. For vacuums, the major pro is that there's a decreased risk of maternal oasis injury, and that they're much easier to use and usually available emergently. The major drawback of the vacuum is that there's an increased risk of neonatal cephalohematoma and that they have a higher failure rate. I'd like to review some hot button topics, not because they will necessarily be directly tested, but because I think that they often come up in clinical practice. Can you use alternate instruments after a failed attempt? The short answer is yes, but it's important to take a more nuanced approach to this. The first study that looked at that tried to answer this question compared the use of combination instruments with a spontaneous vaginal delivery. So of course you would see higher complication rates when going from vacuum to forceps than just having a vaginal delivery alone. However, recently there was a study of about 1,300 nulliparous women who underwent an operative vaginal birth with use of sequential instruments versus single instrument. And they did find a higher increase risk of anal sphincter tears and lower umbilical artery pH in the group that underwent sequential instrumentation. So again, this is not recommended, but if you feel that it is possible, you can use sequential instruments. What is important to keep in mind when you're using the vacuum? That cephalohematoma is more likely to occur as the duration of the vacuum application increases. One study found that 28% of neonates developed a cephalohematoma when the time from application to delivery exceeded 5 minutes. It's important that reducing the vacuum pressure between contractions does not appear to reduce the incidence of fetal scalp injury. And then lastly, should you provide prophylactic antibiotics during operative vaginal birth? And there was a recent study, the ANODE trial, ANODE. They gave prophylactic antibiotics versus placebo prior to an operative vaginal birth, and although the women did have a lower risk of perineal wound infection, there were many issues in this study that likely make it not generalizable to a population in the United States. This was conducted in the UK, where the majority of episiotomies were mediolateral, and that's a reason why why antibiotics could be beneficial, whereas routine episiotomy is not recommended in the United States. And briefly to review some pelvic shape, these are often tested, at least one question. There's 4 major shapes. The first is a gynecoid shape. There's a round to slightly oval pelvic inlet. This is considered to be the most favorable shape for a vaginal delivery. The android, or a triangular inlet, there's very prominent ischial spines and a more angulated pubic arch. This is thought to cause a lot of CPD. The anthropoid shape has the widest transverse diameter, and this is usually thought to be the cause of an occiput posterior presentation babies. And then lastly is platypoid shape. There's a flat inlet with a shortened obstetrical diameter. Usually you have that kidney shape of the pelvis, and this is thought to usually cause a deep OT, or occiput transverse arrest.